Thank you again, Jason. I'm a little bit more relaxed than in the mornings, so I hope you too. So in this section, let's have a journey to inner ear. So I'm going to talk about the specific form of vestibular neuritis. It's very rare, but it's a good example how we understand the vertigo from inner ear. So I believe all of you know the vestibular neuritis is the second most common cause of vertigo from inner ear. So even though this disorder had been described earlier, the term of vestibular neuritis, at the time vestibular neuritis was first coined by Professor Hallpike in 1949 first, and they published this seminal paper on BPPV, Meniere's, and vestibular neuritis in 1952. So do you know why they call this disorder vestibular neuritis at that time? Any idea? So at the time, the Dr. Hallpike believed that the pathology should be there proximal to Scarpa's ganglion, including the vestibular nucleus. So they termed it as the vestibular neuritis, but now we know that it's in the Scarpa's ganglion or in the nerve or the peripheral labyrinth. So we changed the term to vestibular neuritis. So this is the pathology by Dr. Nador in 1995, and all other pathology also showed that the degeneration of the fibers, nerve fibers, and also the end organ in this patient with vestibular neuritis, and this is also the evidence for the viral etiology in this disorder, because in case of the vascular damage, there should be some the fibrosis of the end organ or nerve fibers. So, as you know, the diagnosis of vestibular neuritis based on the acute symptoms of prolonged unilateral vasculopathy that includes spontaneous nystagmus, typical of peripheral patterns, the unidirectional and without direction changing, and mostly a horizontal and torsional beating away from the lesion side and caloric presses, and there should be no auditory symptoms and no other symptoms and signs of neurological damage. But you should remember that the diagnosis of vestibular neuritis is also of exclusion. So there is no confirmatory tool to diagnosis of the vestibular neuritis. You should exclude all other possible etiology when you make the diagnosis. So as you know, the peripheral vascular compartment may be divided into superior and inferior divisions, and the superior division is consisted of the anterior and horizontal canals and utricles, while the inferior division include the posterior canal and saccule. So the idea of selective involvement of superior or inferior division comes from the early ages, and it has been suggested that the vestibular neuritis preferentially involve the superior division, and this concept was supported by the pathology by Schoeneck and Kitamura in 1981, and indeed they found the more involvement of the superior division in pathology of the patient with history of vestibular neuritis. And you also know that the development of posterior canal BPPV sometime after the attacks of vestibular neuritis. So for development of posterior canal BPPV, the posterior canal should be active, should be irritated. So this suggests the relative impairment of the inferior division in the patient with vascular neuritis. And this is the first paper that pursued this issue in 1996. And the authors at the time evaluated the rotational axis observed in these patients with vascular neuritis, and they analyzed the axis of spontaneous nystagmus, and they found that the nystagmus mostly comes from the horizontal canal or from both superior and horizontal semicircular canal, and no one single patient showed any type of nystagmus from the inferior divisional involvement. So they conclude that the vascular neuritis exclusively involved the superior division. And this preferential involvement of superior division is explained by the anatomic variation between the differences between the superior and inferior division. So if you look at the superior division, the nerve fibers runs a longer course and narrow and channels compared to the inferior division. So it may be more susceptible to the viral involvement and secondary vascular damage after swelling of the nerve, because it may be kinked when they was swollen due to the narrow bony channels and longer course. But if you review the previous studies, the pathological studies, this was done by Dr. Bello, my mentor in UCLA, and if you look at the pathology, this is a normal side and this is involved side. But in this patient, this is from the inferior division. So this pathology clearly shows that in some patients, the inferior division is more severely involved. So exclusive involvement of the superior division is not true. Some patients may show more preferential, more severe damage to the inferior division, but we can prove that otherwise the patient dies and we get some pathology. So now with the development of head impulse test and orbital and cervical VAMS, now we can evaluate all 5 compartments, vestibular compartment, and now we can decide whether the superior or inferior division is involved in those patients with acute unilateral vasculopathy. So this is the first study by the Sydney group. They did head impulse test for 3 canals in the patients with vascular neuritis and labyrinthitis, and they also found that most of the patients showed involvement of the superior division or both superior and inferior division. But if you see the individual data, two of the 1833 patients showed exclusively the involvement of inferior division, especially in the patient with hearing loss. So in the patients with maybe labyrinthitis, those patients may show exclusively the inferior divisional involvement. And this is the recording of the head impulse test. You can see here the head impulse is impaired for all 3 semicircular canals in patient. So we may presume that the vascular neuritis may be classified into superior and both superior and inferior and rarely inferior divisional subtypes. So this is the patient actually who made me to be interested in this type of vertigo. This high school student developed acute vertigo on the way home after school in the bus. So he was transmitted to the emergency department at the time, and there's nothing else. And fortunately, we can record the nystagmus at the time. So without fixation, you can see this torsional downbeating in nystagmus. So again, more torsional, but a little bit of downbeat component. So according to the previous, the criteria of classification of nystagmus into peripheral and central, this should be central. This should be central. So the emergency doctor at that time only did horizontal head impulse test, no vertical head impulse test, and the horizontal head impulse test were normal at that time. So they took MRI, and he was admitted. And the next day, when I saw him, the nystagmus already gone, and the vertigo already resolved. So when I did the vertical head impulse test, it was normal at that time. And we couldn't do vertical head impulse test when he had that kind of nystagmus and symptoms. And we further evaluate, and he showed no ocular torsion, normal hearing, normal calorics, and the SBB tilt was normal along with the normal brain MRI. But when we record the cervical BAMs, we can see that there is no wave formation on the right side, but ocular BAMs were normal. Several days later, we follow up the BAMs to see whether the no formation was kind of the lab errors, but we still see the emergence of some waves during right ear stimulation, but it's still quite asymmetric. So this patient presents with acute vertigo without hearing loss and funny torsional downbeat nystagmus, and the absence CBAMP was the only abnormality we can detect at that time. This is another patient, a 40-year-old woman, and she also presented vertigo and imbalance for a day. There are no other symptoms, and he had a history of migraine previously. And again, there's torsional downbeat nystagmus. It's clockwise torsional from the patient's point of view with fixation, and you can see the augmentation of that torsional downbeat nystagmus with removal of visual fixation. So at this time, since I saw her during the attacks, when she showed the kind of nystagmus, I videotaped the head impulse. Left horizontal normal, right horizontal normal, right anterior normal, right posterior, right anterior, and left posterior. Can you see the catch-up saccade during the stimulation of the left posterior canal? So this patient selectively showed the selective impairment of left posterior canal. So we conclude that at the time this should be the inferior divisional type of vestibular neuritis, and we proceed the further evaluation. Again, no ocular torsion and normal hearing, normal calorics, and also the SBB tilt within a normal limit. And but in this patient, cervical vamps were symmetric. So selective involvement of the posterior canal and saccule was spared. And ocular vamps were also normal. So we follow up the patients whether the positive head impulse for the posterior canal is kind of measurement error. Oops. So it became normalized a couple of days later when the symptoms resolved. So the findings of impaired head impulse test for the posterior canal is real. So why this kind of nystagmus occurs in the patients of inferior vesicular neuritis? As you know, the posterior canal innervates, the superior oblique on the same side and inferior rectus and the other side. So this I will show first. So when it is stimulated, there is a downward and exogenous deviation of the eyes. So this fiber is disrupted. There is deviation of the eyes in the opposite direction, and there would be nystagmus beating in the direction of the actions of these muscles. So in patient with selective damage of posterior canal, the nystagmus should be like this torsional downbeat nystagmus. Now you understand the direction of nystagmus, the mechanism of nystagmus in inferior vesicular neuritis. So we also record the spontaneous nystagmus using the three-dimensional video oculography in both patients. And as you can see here, the torsional and a little bit of downbeat nystagmus. So if you analyze the 3D vector of this nystagmus slow phases in each horizontal and vertical and torsional plane, then you can get the rotational axis, and you can compare the rotational axis of the nystagmus with the known the axis of each semicircular canal we get from the normal, the anatomical data of that orientation of each canal. So if you look at the figure here, you can see the axis of each nystagmus, and it is quite aligned with right posterior canal. So it indicates that the nystagmus mostly came from the destruction of that canal. So in the second patient, we also did rotational axis analysis, and again, the axis is best aligned with left posterior canal. And we also recorded the head impulse, VUR gain, using the magnetic search coil techniques in second patients. And indeed, first I'm not sure, but we indeed find that the gain is selectively decreased for right posterior canal in this patient. So we decide to analyze the data of all the patients with the diagnosis of vesicular neuritis or labyrinthitis in our lab, and we could find 7 more patients with this type of torsional downbeat nystagmus with nothing else. And we analyzed the data, and the diagnosis was based on these criteria, so acute vertigo and vesicular symptoms including imbalance and torsional downbeat nystagmus, and head impulse only abnormal for posterior semicircular canal, and abnormal cervical vamp, but normal ocular vamp But ocular BAMP wasn't available almost all the patients because we started ocular BAMP in after the 2000. So and normal calorics, and we did brain MRIs in all patients to rule out the central lesion. And you can see here the patterns of spontaneous nystagmus is mostly a torsional downbeat, and head impulse was abnormal only for posterior canal. And of interest, the OTR wasn't observed in these patients, and the calorics are only abnormal for those with hearing loss, and showed progression into whole involving whole compartment. To summarize, the inferior vesicular neuritis is quite rare. It's in our data, it's only 1.73%. But I should confess that we might have missed many cases because, this kind of presentation, we suspected central vasculopathies, mostly maybe by me or by my resident or fellows. So I'm not sure whether this data is comprehensive, but we can see at least some patients with problems from the inner ear can have selective involvement of the inferior division. And you should remember that in this patient, in the patient with acute vertigo and torsional downbeat nystagmus, you should check the cervical BAMPs, and you should check head impulse test for vertical canals. And fortunately, the prognosis is quite good. So most of the patients showed a resolution of the symptoms and signs in a day or two. So you don't need to much worry about this. So now we can classify the vesicular neuritis into superior and inferior and total, depending on the patterns of spontaneous nystagmus and the patterns of head impulse test impairment and the other test. So this is the typical case of superior divisional involvement. You can see the horizontal torsional nystagmus, and the rotation, the axis of the spontaneous nystagmus lies between the horizontal and anterior canal, and ocular torsion toward the lesion side, normal audio but caloric paresis, and the decreased or no formation of ocular BAMPs, while the cervical BAMPs are normal. So this is the typical case of the superior divisional palsy of vesicular neuritis. In contrast, this patient, as I showed before, shows only torsional downbeat nystagmus and only a absent formation of cervical BAMPs. So in conclusion, in patient with acute vesicular syndrome and the patient shows torsional downbeat spontaneous nystagmus, you should consider the vertical head impulse test for the posterior canal. And sometimes it is tricky, but you can detect, and better with video-based head impulse modification if you have. And if there's impaired head impulse test, you don't need to worry about that. It will just go away. If the head impulse test is normal, what you should think about? If the head impulse test is normal, cerebellar infarction. So cerebellar infarction occasionally shows this type of torsional downbeat nystagmus. So the findings of head impulse test, vertical head impulse test, is critical in diagnosis these patients. So we published this in several years ago. So you may refer to this article if you want to get some more information. And thank you again.